Hey guys, welcome to this short presentation on anaphylaxis with a particular focus on the management of shock. Today we're going to delve into the pathophysiological mechanisms behind the cardiovascular symptoms we often find in anaphylaxis, as well as the tools we have at our disposal to address these issues in the pre-hospital setting. That's coming up, but first let's have a basic look at anaphylaxis more generally. So anaphylaxis will invariably be characterized as a severe allergic reaction with a rapid onset, which can have some fairly dire consequences, including death. It represents a systemic inflammatory reaction resulting in the degranulation of granulocytes such as mast cells and basophils. And they degranulate inflammatory mediators such as histamine into the bloodstream. The result of this is a systemic inflammatory cascade which results in potentially life-threatening symptoms across multiple body systems. Now, these symptoms can be quite wide and varied, like anything from diarrhea to airway obstruction through swelling and occlusion. And they relate to the way in which the mediators released by these cells involved in this process attack the different receptors at the different sites throughout the body. And because the symptoms are so varied, it helps me to break them down into what I call a distinct set of syndromes within anaphylaxis. As you can see here, I've laid them out in my way of thinking, which is through the cutaneous syndrome, which includes urticaria, itching, and the flushed appearance that you see sometimes. The asthmatic syndrome, which is where you'll see your bronchoconstriction or wheeze, chest tightness and shortness of breath. So essentially all of asthma contained within the setting of anaphylaxis. The edematous syndrome, which involves swelling to the face, lips, tongue and larynx, where we'll start to see our stridor and our difficulty in swallowing. And this is sort of distinct from the cutaneous syndrome in the sense that the edematous syndrome I like to relate to the face and airways, upper airways, rather than urticaria, which is actually edema, but it's just a sort of a whole different kettle of fish when you're talking airways. Your gastrointestinal symptoms include nausea, vomiting, diarrhea and pain, and that's to do with the sort of gastric motility and the cramping that's happening as the histamine really gets to work in there and starts squeezing things around. And the cardiovascular syndrome, which is the sort of topic for us today, which is where you'll start to see a tachycardia, hypotension, your pallor and diaphoresis. So when we're making an assessment of someone who we suspect might be presenting with anaphylaxis, it's pretty important to get a few key pieces of our history nutted out. We know that anaphylaxis presents with a sudden or rapid onset of symptoms. So someone who's had, for example, the symptoms we talk about with the gastrointestinal syndrome, diarrhea and vomiting over the course of 48 hours, might lead us away from like an acute anaphylactic reaction, maybe more towards gastro or something like that. We need to consider their past presentations, and that includes sort of whether they've had a known allergy to something in the past and whether they've had a further exposure of that again today, and this is how they presented last time and these are the type of symptoms that they had. We also need to gain a bit of a history around the history of their exposure to what we suspect is the antigen involved in this instance. So say, for example, and this was a case I attended, was a young girl who'd had some guinea pigs for only a month or so, and she'd had about 3 or 4 plays with the guinea pigs over that month, and each time she developed a rash which was getting worse, and then on the day where I met her she was presenting in anaphylaxis after playing with the guinea pigs. So there's a clear sort of progression in that sensitization and then activation of that inflammatory cascade happening there in that history of exposures. We need to consider our physical findings, and these are the syndromes that we talked about before. Ambulance Tasmania uses the rash mnemonic here, which is neatly stolen from Ambulance Victoria, which is what we like to do. So R for respiratory distress, shortness of breath, wheeze, cough, stridor. A is for your abdominal symptoms. S for your skin or mucosal symptoms, so your angioedema and things like that. And H for your hypotension, which is a key killer. When we look down to sort of how we make decisions about intervening in anaphylaxis, this is what we would use in Ambulance Tasmania. And if you look at our last point, so any patient who has a known allergen and basically a sniffle gets adrenaline. We also tie in our vital sign survey. We expect to see changes in our vital signs sort of consistent with anaphylaxis. So our heart rate might rise initially. Before then, if we end up becoming hypoxic, we might brady out. Initially, BP and anaphylaxis will probably rise and then drop quite rapidly as you start to involve your cardiovascular system and the sort of changes you might get with shock. SpO2 is important to check, particularly if there's any stridor or wheezing involved. And I put temperature here because it's important to note that we are sort of talking about like an inflammatory cascade here happening, right? So we can expect there to be sort of pyrogenesis or a little bit of heat generated. And if we're looking at someone who's been stung by a bee with a bee allergy and they're vomiting and have diarrhea everywhere, and they've got a temperature of 37.5, we probably won't go ahead and call that gastro. We might give that adrenaline. And speaking of, that's how we're going to manage it, right? So adrenaline is the mainstay treatment in all cases of anaphylaxis, and that's IM adrenaline in the first instance. There's various reasons for that. First of all, it's quick. Like, it's quite easy to get an IM injection in fairly quick, particularly in someone who's quite vasoconstricted and quite shut down, where you might have to stuff around for a while to get a line. And it simultaneously addresses all the big killers, as the ABCs. So it'll simultaneously address your airway edema that's causing your stridor. It'll give you some bronchodilation to sort of overcome that asthma syndrome. And it will improve your circulation through both your cardiac output and your peripheral vasoconstriction. And very importantly, it prevents mast cells from degranulating further histamine. So it will actually stop the release of the histamine, which is causing you all these problems in the first place. So once we've jabbed up with some IM adrenaline, we need to start looking at other things like our basic supports, IV or IO access if the situation's dire, position and oxygen, those sorts of things. Now, for mine, in my personal practice, I'll tend to move very quickly to an adrenaline infusion. I understand a lot of people won't have that available to them, but in my intensive care practice here, that's probably where I'd move. In lieu of a second dose of IM adrenaline, I'd probably go straight to an IV infusion. And that's because it's more easily titratable, and you get an instant concentration of adrenaline within the blood. Okay, so when you're giving IM doses, it takes probably up to 10 minutes for that IM adrenaline to reach peak bioavailability in the blood. So the effect is that you end up stacking your doses if you're giving it every 5 minutes. So you'll get big peaks and big troughs. The infusion's readily titratable, and it works the same way as your IM adrenaline anyway. Your further pharmacological interventions, so your second line and third line treatments, which are sort of de-emphasised through the literature and through the recommendations from allergy councils, etc., but not to be forgotten. So just because there's a push towards IM adrenaline doesn't mean that we should forget all these other things that could add some benefit, be it fleeting or not much. But they're there to use for these syndromes, as this table says. And so that brings us to the management of shock. In anaphylaxis, shock is one of the big killers. And if you've ever been faced with someone who's presenting an anaphylactic shock, you'll know how labile that blood pressure can be. You know how it can sort of recover with IM doses of adrenaline, but then plummet back to whence it came. So it can be quite tricky. So let's look at some of the pathophys and some of the strategies we can employ to sort of get on top of it. Shock in anaphylaxis occurs via two primary mechanisms, right? So histamine promotes widespread vasodilation, both on the arterial side of the circulation and on the venous side, so the post-capillary side. And we also see an extravascular fluid shift through sort of more porous capillaries into the interstitium. That's where we'll start to see our edema and things like that. It's considered a form of distributive shock, but the true cause is sort of multifaceted, right? So when you're talking about a fluid shift into an interstitial space, that's more of a sort of like a hypovolemia, so like a relative hypovolemia. So it's realistically, it's a mixed shock. And then when you add other factors that could come into play at causing hypotension in anaphylaxis, it can be a mixed bag. So for the purpose of what we're doing here, we're going to look primarily at the vasodilation and the fluid shift factors here. So to help explain some of these concepts, I've put together this little diagram here, which I'll try and explain. Across the top section, we have our sort of normal microcirculation, so our normal capillary bed being fed by an arteriole and drained essentially by a venule. We know that capillaries consist of a single layer of endothelial cells, which allow for diffusion of oxygen and nutrients freely between the gaps in the cells. We know that arterioles have this layer on the inside, but then are wrapped with a layer of smooth muscle, which controls the flow of blood into the capillary through contraction and relaxation. And then around that smooth muscle layer is a tunic of connective tissue. In the setting of anaphylaxis, this sort of normal regulation is lost, whereby histamine sort of interacts with endothelial nitrous oxide within the endothelial cells of the arteriole, and endothelial nitrous oxide synthase unsurprisingly synthesizes nitric oxide. And we know what that does, right? Because we use GTN to dilate vessels all the time. So nitrous oxide activates cyclic GMP, which depletes all the intracellular calcium within the smooth muscle layer of the arterioles. And what this does is, with no calcium you can't contract, so we dilate. As the arterioles dilate, they actually pull apart the cells in the capillaries, right? So those junctions between endothelial cells get stretched and the gaps become bigger. That's what we talk about when we get like capillary permeability or capillary porosity. We're literally stretching open those gaps. What this allows is for from the arteriole side, a significant inflow of blood into the capillary bed, so increasing hydrostatic pressure within that capillary bed, and increased diffusion through wider gaps. What that results in is some edema. This is where we get a large portion of our fluid shift. At the other end, we also get a significant dilation in our veins and our big vessels, like our central vessels, and we end up with quite a significant amount of blood pooling, which also contributes significantly to like a decrease in venous return through that decreased central venous pressure. And then finally, we need to probably consider some other causes for our shock in anaphylaxis. So it's not all just blood vessels and fluid shift. We can have a failure of our pump, like in the example of a Kuhn syndrome, which is, if you think about it, like a wall motion abnormality or an infarct, which is causing that pump to fail. Or an obstructive cause, such as increased intrathoracic pressure, like we might see in our asthma syndrome. Someone might be gas trapping and compressing their major vessels, and we know that with their central venous pressure already depleted, it's not going to take a whole lot of extra increased intrathoracic pressure to really cut off that vena cava and prevent that what little venous return there was sort of coming back into the heart. So what's the result of all that? Well, with a decreasing central venous pressure and decreasing venous return, as well as a shift of up to 35% of our volume into the interstitium and a complete loss of our systemic vascular resistance through our arteriole side, we're going to end up hypotensive, right? We're in shock. So the question is, what are we going to do about it? How are we going to approach managing someone who is in shock secondary to anaphylaxis? So thankfully, we've got a few ways that we can sort of come at this problem. When we think about the perfusion equation, as I'm calling it here, like our mean arterial pressure is equal to our cardiac output times our systemic vascular resistance plus our central venous pressure. Each one of these variables is interdependent, and we can affect MAP by changing any of those in isolation. So in terms of our cardiac output, we might look at applying an inotrope. So giving some adrenaline IV to sort of increase that rate and forcefulness of contraction. If adrenaline's not working for that sort of cardiac output side of your equation, you can maybe consider giving some glucagon, which would work through a non-adrenergic pathway. So say your patient's beta blocked, you're throwing adrenaline at them and nothing's happening, give them a spin of glucagon and see if that helps. So to improve our systemic vascular resistance, we've got vasopressors. We'd like to really target those alpha receptors. So any agent that will target your alpha-1 receptors, which are really sort of the ones that are controlling that tightness of your arteriole, sort of your precapillary sphincter, those are the ones that we want to really get into. So adrenaline will work quite well, and it also works for your cardiac output. That's why it's the drug of choice, as well as its mast cell properties. But failing that, there's other things that work on alpha-1, such as metaraminol. And for our central venous pressure, basically the only thing we can really do there is just pour a bunch of fluid into it. Increase the volume of the fluids within that space and hopefully increase that central venous pressure. We know that someone in anaphylaxis is probably going to have a central venous pressure of nothing. So really, like, you can basically drop that part out of this equation when you start to look at your MAP equation, but it's there. You can add to it. You might be able to boost, and we know that sort of fluid replacement is going to be important in patients who have lost that fluid into their interstitium. Now, adrenaline's where we really want to go with this. Like, our infusion of adrenaline is going to be beneficial on a number of fronts. Firstly, it agonizes all the adrenoceptor types and subtypes. So we're getting all our beta effects, we're getting our alpha effects, we're getting bronchodilation, and everything's happening all at once. But when we look at our sort of our beta 1, so our heart, and our alpha 1, which is our vessels, we find that that its effects on those subtypes is very dose dependent. So at lower rates, we tend to increase our inotropy and chronotropy, so we attack our beta 1s, or the cardiac output side of our MAP equation. And at higher doses, we start to push into that alpha squeeze. So we start to bring our vascular resistance up by inducing a peripheral vasoconstriction. So I'd be looking at moving to an adrenaline infusion fairly early, as I've said before, and I'd probably start at about 10 mics a minute, and I'd start to bump it up from there. And so let's finish off with a quick case, hey? So in this instance, let's say you're an ICP, you've been called to assist another crew who's attending an anaphylaxis. They have arrived to find Mr. Brian. Brian was at a maker's market, testing his hand out at the beekeeping demonstration, knowing full well that he has a bee allergy and that he gets very sick, in his words. So of course he was stung, and the onset of his symptoms was over a couple of minutes. He used his EpiPen, which he carries with him, and the arriving crew gave him 2 more doses of IM adrenaline, which they report gave him a transient improvement in his condition, but then he would slip back to being crappy again. They've also given him 750 mils of saline because he was hypotensive. On assessment, he's itching all over, he's pale and clammy, and he's persistently hypotensive despite the adrenaline that he's had and the fluid. He's got angioedema to his lips and his tongue with an audible stridor. Now, the crew says that this has actually got worse since they've started managing him, even in spite of the adrenaline. On his vital sign survey, his heart rate's 100, his BP is only 70, and his SpO2 is not reading. Doesn't appear to be super respiratory distressed at this point, but he is having trouble dragging that air through. His temps of 37.5 and his rhythm is sinus. Now, there's a couple of considerations here. A, Brian's got a shitty airway, right? So we need to be very mindful of that. We need to maybe think about our options for front of neck access if things go bad, or at least keep that in the back of our mind. And since we have such a significant airway issue, I'm just going to jump straight in with a repeat IM dose of adrenaline. It's just quick and dirty, takes no time at all, and it will just get that concentration back up while I get ready my adrenaline infusion. And while I'm doing that, I am going to be asking my friends on scene to get an adrenaline neb to really attack that angioedema from another angle. Thinking about that angioedema in the presence of hypotension, there's a bit of a balance, right? So we've got to think about how much fluid we're putting in and where that fluid's going to end up. So we know that our crew initially gave 750 mils of fluid for hypotension, and that his stridor actually got worse after that. So, you know, maybe there's an element of that fluid that's pushing into that space around that larynx that we probably just want to be quite cautious about. Maybe we'll move towards a bit more squeeze. Maybe we'll look to titrate our adrenaline infusion a bit quicker than we would otherwise. And that's how we're going to manage the blood pressure, right? So we're going to look at our adrenaline infusion as our main tool in the management of shock in anaphylaxis. And just the last point here, which I should mention, we'll just do a secondary sweep for stingers, hey, and we'll make sure that there's no more venom producing the reaction in the first place. And here endeth the journey. Thanks very much for watching.